Hello and welcome to Differential Discussions. I'm Melissa.
And I'm Dave.
And we're still talking about red cell morphology, and today we're going to talk about sickle cell disease.
Yeah. So sickle cell disease is a inherited hemoglobinopathy, one of the most common hemoglobinopathies worldwide. Genetically, it affects the beta globin genes. And for sickle cell disease specifically, both genes would be affected. So we have two mutant genes affected. And I believe it's the sixth position on the beta chain, a glutamate to valine, I believe, is the substitution, which creates an opportunity in low oxygen saturation situations for there to be a polymerization of the hemoglobin S, and the resultant crystal formation kind of gives the cell this sickling kind of shape. There's a lot of downstream effects from this mutation, but and maybe we'll touch those a little bit as we go. But yeah, a really horrifying, debilitating disease for those that have it, and I'm sure it costs the United States and different countries around the world a lot in healthcare costs and treatment and stuff. But yeah. Anything to add, Melissa? I might have missed.
No, I think that's good for an overview. Yeah.
Cool. So yeah, here we are looking at an SS patient. Mm-hmm. So they have two genes affected here, and we can see some of the telltale signs of sickling, sickle cell disease. Yep. This is quite representative of a lot of the SS that I've seen in my career. So we have some codocytes, target cells, a little bit of polychromasia I can see here too. So hemoglobin S disease classified as a normocytic normochromic anemia. You have some hemolysis and decreased red cell survival. So not uncommon to see elevated reticulocytes and the resultant polychromasia from the shift red cells showing up. Teardrops, fairly common. We'll have varying morphologies as the spleen loses its function. Some of these patients have, it's been removed surgically as part of treatment prevention. So you'll get lots of different inclusions, Pappenheimer bodies, Howell-Jolly bodies. Yeah. And then of course our sickle cells. So I think the textbooks would typically describe the sickle cell, and as the name implies, kind of like a bladed harvesting tool, the sickle. You will see ovalocyte looking cells. And I think one of the things that really shows sickling in the way that I kind of like to see it is part of the pathophysiology of when a sickle cell crystals form is you get a dehydration of the cell, which concentrates the hemoglobin, gives this kind of bright red, rich kind of tone to it. So any cell, once I kind of get the idea that I'm looking at a possible sickler, anytime I see an ovalocyte, I'm looking for subtle little points, jagged edges, and that deep red color. If I see that, then I'm gonna probably call them as sickle cells. So, all right, I'm sucking the oxygen out of the room. So.
I think one of the important things, especially for newer techs and for students, is that when they think of sickle cell, they expect every sickle cell to be a perfect sickle shape and pointed edges, and a lot of times they don't. And especially once patients undergo treatment, then the edges get blunted and it looks less like a sickle and more like an ellipto-ovalo, or even like a hemoglobin SC crystal, which there'll be a separate video on hemoglobin SC. But once you start treating the SS patients, they look really wonky and they don't look like beautiful sickle cells.
Yep. No, absolutely. But we still want to represent to the clinicians that, there's abnormal cells present to whatever, value that information might be. But yeah, I mean, you pointed out this one, right? This is very suspicious to me given its color.
Yep.
I think your pencil right there is on a suspicious cell.
Mhm.
These right here, right? You don't necessarily see good sickling, but the color's right. And once we're in that calibrated mindset of sickling going on, then I just start kind of, they become a little bit more apparent.
Well, the other thing is that the ones you just pointed out is they're sticking to each other.
Yes. And that's, I before we started, I said, let's just touch the patho. And then I was, bleh, right? And so, so maybe real quickly, the stickiness, this is kind of part of the pathophysiology of sickle cell disease. Red cells that are sticky, that stick to each other, that stick to the vasculature, not good for business. We want blood cells to flow unimpeded through small capillaries and deliver oxygen to the tissues. Sticky cells are bad. These cause a vaso-occlusion, which further lowers oxygenation to the relevant areas. A lot of what makes sickle cell disease so bad is it just kind of, it runs away, right? It's
that snowball effect.
Definitely. Yep. So yeah, not uncommon to see some cells sticking together like that.
Yep. Yeah. All right. And the fields?
Yeah, sure. Let's look around a bit. Cool. Got some white cells.
Yeah. So we've got two neutrophils.
We do.
Over here. And then this looks like a lymph.
Yep.
He looks a little disheveled, but it looks like a lymph.
Yeah.
And then there's a platelet sitting on top of this cell over here.
You almost can't teach this enough, can you, Melissa? So, and what's cool about that is we see a little white halo around that platelet, kind of letting us know and reaffirming that this is outside of the cell and on top of it. If it was an inclusion, you wouldn't see that white halo.
Right. And I think that's important in sickle cell because there's so many inclusions.
Yep, absolutely.
Just making sure that the students or the newer techs can recognize that it's a platelet and not an inclusion.
Yep. And thrombocytosis, not uncommon with a sickle patient too, right? So sometimes you will see an elevated platelet, high normal platelet. So more opportunities for platelets to be on red cells.
Yeah. So that's due to a couple things. Inflammation. Platelets will always increase during inflammation. And it may not increase above the reference interval, but it'll increase above the patient's baseline. So it really depends on what the patient's baseline is before the inflammation. Or the other reason is these patients have issues with their spleen, and the spleen, it stores about 1/3 of all circulating platelets.
Right.
So if you just had a splenectomy or if your spleen's acting up, then your platelets are not going to be housed in the spleen any longer, and you're going to have a temporary increase in your platelets because of that.
That's a good point. It's cool. Other things that we're looking for, not related to the red cells necessarily too, is you may see a bit of a left shift. Not uncommon to see some immature granulocytes, maybe a slightly elevated white count or like a high normal white count overall.
Absolutely. All right, well, and then there's codicytes.
Codicytes.
Now, we're going to see codicytes whenever there's a hemoglobinopathy. So that's not unique to sickle cell, but it is one of the characteristics of sickle cell.
Absolutely.
And then polychromasia, like you mentioned earlier.
Yep.
And then there's sickle cells abound. So this guy looks all folded on himself.
Yep.
And then it looks like there's two right here.
Yeah, that is cool, isn't it? They're kind of
this.
Yep.
It's two perfect sickles too. They almost look like the ones that students imagine as sickle cells.
Yep. And I'm just pointing out that for me right here, there's some shape stuff, but it's the color. The color is just like, hey, Dave, look at me.
Yep.
Pay attention.
Absolutely. It's the color and the sticking to each other.
Yep. Another thing I'm noticing that is not necessarily not associated with sickle cell disease is a bit of hyperchromia going on too. I'm seeing. So I'm seeing a central pallor that exceeds the 1/3 I expect. So I'm just kind of like noting that. Cool.
Right.
For inclusions, it doesn't look like a ton of inclusions either, right?
No, I mostly see, like, it looks like down here, like in this one I
Couple
pointed out
paps.
earlier, there's 2 PABs.
Yeah, yeah,
And there might be like a PAP here and another one here
yeah.
around. But yeah, I'm not seeing a whole lot for inclusions in this one.
Cool. Check out some more.
And don't forget, basophilic stippling is just going to be hard to see.
Yeah, 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 absolutely. Very pretty. Yeah, this is good. That's a good one, right? That's supposed to be an arrow.
Yeah, and it's like he's all stuck to all the other ones.
Yes. Yep. Not Rouleau.
Not Rouleau. This is the stickiness of sickle cells.
Yes. So if the phenomena of them sticking together is isolated to sickling cells, it is not Rouleau. This isn't like a typical shape, right? But I'm noting that that deep red.
Yep. It's that concentrated hemoglobin. You think you said earlier, dehydrated, right? So it's that nice color. It's typically a little bit darker than spherocytes, unless they're like microspherocytes, and then they have a kind of similar kind of coloration to them. But this is generally a deeper color than what you see in just regular spherocytes. So mostly sickle cells and podocytes.
Podocytes, yeah. Other things you can see too, not uncommon to see nucleated red blood cells, especially in pretty severe crisis.
Yep.
As the bone marrow responds to its EPO signals, it'll start pushing out NRBCs. So far, none, but.
Yep.
Oh yeah, look at this little. It's like a trio up there.
Yep. Yeah, there's a bunch of really good
Oh, this is beautiful.
ones in this field.
I love that too.
Yep. So more of the sticky drepanocytes, the sickle cells, and then some podocytes. And actually, it looks like there's an inclusion right there.
Oh, cool. Cool. That's Howell Jolly, perhaps?
Yeah, I think that's a Howell Jolly. Mm-hmm. Cool. All right. Let's move around. See what else we can find. Ooh, there's a nice one.
Ooh, wow.
Nice Howell Jolly right there.
Yeah. At what point is it an NRBC?
No.
Yeah, that's a big one. Oh yeah, another cool phenomena here that we see. So actually, I'm gonna let me clear that. Do the arrow from the bottom here. So it takes a little bit of careful analysis, but you can actually see like it's like a banana, I guess, is the. And that's very, very common to have see right where the central pallor would be in the red cell. It just kind of folds up. Pretty good sickle cell there.
And sometimes they fold up like that, and sometimes they fold over.
Yes.
So like you get one of the sides folded over, and it looks similar. I think this one has it. Like you can see right here, it kind of looks like there's a whitish line right there. So it's probably folded like this.
Yep.
Typical of sickle cells.
Yep. So we definitely want to call those as sickle cells.
Yep.
And then, following the pattern, see another series of cells kind of sticking together. There may be a regular erythrocyte kind of, well, not regular. It has hemoglobin S in it, but maybe a non-sickle cell there. But yeah, that sticky sickles. Even up here too.
Yep. Yeah, and then just to the right of that, there's another platelet on a red cell.
Oh yeah, right in the central pallor. How pretty. Cool. This looks like kind of a low white count too, huh?
Yeah. Yeah, there's not a ton of whites.
Yeah.
Yeah, so there's just these like sickly ones. Like this one you can tell is a sickle cell, even though it looks kind of wonky here.
That's not a stomatocyte. Please don't call it stomatocyte. Yeah.
Yeah.
Even stuff like I from time to time I'll get students kind of go on a stomatocyte kick. You have to be, so like with this particular cell here, so this has nothing to do with sickle cell, but that cell is on top of another red cell, which is causing it to fold up. So be careful to think about the physical forces that are on the cell that are going on that cause it to have, I would say this stomatocyte is an artifact of its just physical circumstance. Don't call them stomatocyte. Yeah.
All right. Do you want to pull out a slide where it's really bad sickles and we can take a look at that one?
Yeah, sure. Why not? Yeah. Yeah, that might be valuable to get another patient in the mix here.
And this one has an RBC. I'm just gonna pull it out.
But yeah, our sicklers that we see, they're not monolithic. You must consider, did this patient come in for a routine examination or are they in an active crisis? Because you're going to get a spectrum of presentation, even from the same patient, just depending on the circumstances. Yeah, wow. How pretty.
Let me pull it over a little bit so you can see that better.
So yeah, this patient is almost certainly in an active crisis. There's a lot of sickling going on here, a lot of disease. And now these are doing, this is like a textbook kind of sickling.
Yep.
We even have some kind of weird kind of pockets of hemoglobin. Looks like there's an area that's kind of devoid of of hemoglobin there.
So that's what I'm saying. Like that one, almost that cell you pointed out looks almost like an SC crystal.
Yes.
But if you think about hemoglobin SC, you're not going to see all these sickle cells. You may see a sickle cell occasionally, but really SC is codicytes, SC crystals, and an occasional sickle. So when you're seeing a ton of sickle cells, even if you're seeing things that look hemoglobin C-esque, it's sickle cell disease and not hemoglobin SC.
Right. It might be a good time too, where relevant. So in a clinical setting, you might get a medical history, right, to kind of understand best, what the patient has. Most likely, if someone has either a compound heterozygous or a homozygous hemoglobinopathy, it's already been diagnosed. There's already electrophoresis or genetic testing available. So that might assist you too in kind of discriminating whether or not to call something like SC. But yeah, you're right. I've never seen an SC patient have this many sickle cells. There's a lot.
No. And I just want to point out that there's an NRBC.
Yeah. Yep.
So it's common to see NRBCs, especially when the patients have this many sickle cells.
Yeah. Yeah.
All right, let's move to another.
Yeah, just kind of looking at the patho a little bit more, you have this decreased red cell survival. So the marrow is just constantly turning out these not ideal red cells.
I just wanted to show off this basophil.
Yeah, it's pretty, isn't it? So pretty. And I'll comment on the color of the cytoplasm of basophil. If we can look beyond the granules, sometimes you'll have less granules in a baso. That color is a basophil cytoplasm color. It's just got a different character to it than a neutrophil. And I don't have the vocabulary enough to express color-wise the difference, but.
Yeah, it's a different shade. It's a different coloring. It's a different way to look at it. I mean, look at the neutrophil. The neutrophil's right next to it. So there's a neutrophil here on the bottom.
Yep.
For clarity, the neutrophil is here and the basophil is here.
Right. Beautiful sickle cells on this slide, though.
Yeah. Oh, yeah.
So,
lots of them. Let's try to move to a better area. Here we go. That's clear.
how cool.
Yeah, this was a really good slide.
Yeah.
Tons of sickles, like really, really nice looking sickles like this guy over here.
Yeah.
But then you also get some that look more elliptocytic, like this guy here, where he still has blunted edges
Mm-hmm.
and not the sickle pointiness. So those are the kind of sickle cells that we've been talking about.
Mm.
Cool. So I think for the other slide, we would probably have called like sickle cells, codocytes. Maybe that's about it.
And then inclusions.
And maybe the inclusions, yeah. Pappenheimers or Harlow-Jollies.
Yep.
Yeah. And then for this one, tons of sickle cells.
Yeah.
We wanted to look around a little bit more too at this one to see if we wanted to call schistocytes.
Right.
Sometimes when it's really bad like this, you want to call schistocytes if there's schistocytes present. I don't really.
Yeah, no,
really
it just
crazy sickles.
And this is a funny thing too. Sometimes the result reported really doesn't tell the visual story like we might, because this might actually have similar grading to the previous slide, but to our eye is more severe, right? This is clearly a more severe.
Yep. Absolutely.
So pluses and only go so far sometimes.
Yeah, absolutely.
Cool.
But yeah, a couple of different takes on the way sickle cells would look in sickle cell disease. And then sometimes you're going to have slides where there's barely any sickles on them.
Yeah. Yep. So just because a diagnosis exists of sickle cell disease, please let the truth of the slide, guide you. You need to be calling what you're visually seeing. I think one of the biggest mistakes students make that I notice is they anticipate what's going to be on the slide, and then that distorts what they report. Don't let that happen to you.
Or if you're a tech working in the field, then you look at the previous result. See who reported what right before you. But, when you're really working in the field, it's like every slide is an unknown.
Yes, that's how it should be treated.
Yeah.
I'm all for doing a diff, doing an assessment and looking at the previous. I think that's fine to see the clinical trend of what's going on, but really don't let that influence to a high degree what you're doing. Yeah,
so both techs and students, we're talking about.
Yes, looking at you. And I will say transparently, I'm guilty of these sins in some way or another, right? Like I think I've made mistakes before and I've learned from that. So learn from my mistakes.
Yeah, absolutely. That's what learn from our mistakes.
Yeah.
All right. Well, I think that's all we've got for sickle cell. So thanks for watching.
Yeah, thank you for your time.
Please like, subscribe, and hit the bell if you'd like notifications whenever we post a new video, and feel free to reach out to us on social media or via email with comments or suggestions about future content. Thanks.